Welcome back to Ask Dr. Mingle. It's great to see you again. I am Dr. Dan Mingle, family physician, founder and CEO of Mingle Health. I'm here to answer your questions about value-based care and value-based payment. We've been working through this proposed rule in bite-sized topical pieces, which included a fresh orientation to the rulemaking cycle and the related resources to learn more about it, rules relating to the basic quality payment program with MIPS and alternative payment models, MVPs, that is MIPS value pathways, the Medicare shared savings program, this presentation on the new ambulatory specialty model proposed in the set of rules, and we'll also get to a review of the Medicare requests for information included in the proposals. In this episode, we'll introduce the essentials of what Medicare is describing as the ambulatory specialty model proposal. It is an alternative payment model through the Center for Medicare and Medicaid Innovation. It's to cover two high-cost chronic conditions and the specialists that treat them. It's proposed as an initial 5-year trial with a study group and a control group design. Randomization is proposed at a geographic level, and there's mandatory participation proposed as individuals for eligibility. As a proposed time frame, in this current year, 2025, they propose to make the random selection of 240 out of 600 distinct communities. In this year, publish a provisional list of 2027 eligible practices, publish a final list of those eligible practices by August of 2026, begin the first performance year in January 2027, with the first annual data submissions due by March 1st, 2028, the usual pattern of performance year, submissions, then payment year. First payment year to begin on January 1st, 2029. The final performance year to end after a 5-year run, December 31st, 2031, with the last annual submissions due in that next quarter by March 31st, 2032, and the adjustments paid out ending December 31st of 2033. There's some variation on the usual scoring expectations we've come to be accustomed to in MIPS, with a change in perspective to call it 50% of the score based on quality, 50% based on cost, and still including promoting interoperability and improvement activities in there, but viewing them as reductions to the quality and cost score rather than additional elements. Now, it comes out to the same thing, but a change overall in the weights. In the MIPS program, of course, you're used to 15% on improvement activities and 25% on promoting interoperability. They switch in importance and reduce overall. So if you were expressing it in the same terms as MIPS, you'd call it 35% quality, 35% cost, 10% promoting interoperability, and 20% improvement activities. Now, they're also talking about a potentially higher adjustment, starting with plus or minus 9%, using that range more thoroughly than they typically do in MIPS, and potentially increasing the range to plus or minus 12%. They propose to focus on two high-cost chronic conditions and the specialists that often provide the plurality of care for these conditions, excluding primary care providers from these two measure groups. One of those conditions, heart failure, on which 3.5% of total Medicare Parts A and Part B spending, and the 25,000 general cardiologists that are generally involved in their care, base the measure roughly on the Advancing Care for Heart Disease MIPS value pathway, and you include also chronic low back pain, which accounts for about 2.7% of total Medicare Parts A and B spending. 75,000 specialists are generally involved in routine care for these chronic back pain patients, usually receiving care in anesthesiology, pain management, neurosurgery, orthopedic surgery, and physiatry, and based the measurement on rehabilitative support for musculoskeletal care (MVP). Now, the heart failure measures, they're proposing a solid set of measures, no choice in this, an administrative claims measure, that is number 492, unplanned cardiovascular admissions for patients with heart failure. And they're proposing to require submission of 4 measures: beta blocker therapy, ACE inhibitor therapy, controlling high blood pressure, and functional status assessments. And one cost measure, that is the heart failure episode-based cost measure we're already seeing as part of that Care for Heart Disease MVP. Low back pain measures, similar approach. One administrative claims measure proposing to be overuse of MRI for back pain, which is the specs of which have yet to be developed. Submitted measures, including the high-risk use of medication in older adults, screening for depression and follow-up plan, BMI screening and follow-up plan, functional status assessments, with the cost measure being the existing low back pain episode-based cost measure in that musculoskeletal MVP care group. They're proposing an approach to measure achievement points as they do in other MIPS categories at this point. No points if you don't report the measure, no points if you report it but with less than 75% data completeness. Not scored, therefore just take it out of the calculation if it lacks a benchmark, and not score if your submission is under the case minimum of 20 patients. Now, for the cost measures, the heart failure and the low back pain cost measures, proposing as usual a 20 case minimum on those. Those cost measures will give you a cost score as part of your overall MIPS score for this category, and to establish eligibility for participation. Benchmarks are proposing to establish on the performance year data with scores ranging from 1 to 10, median performance set at 6, and disperse the range of points above and below that median by standard deviation, similar to what's being done today for cost measures, and so some other categories. They're proposing 2 practice improvement activities in common to both of these measures or both of these cohorts. One is connecting patients to primary care if they don't have a primary care physician, and second, to communicate and collaborate with primary care in the provision of care by specialists to these patients. For practice improvement activities, you either, it's pass-fail, as most practice improvement activities are. If you pass them both, you don't subtract anything from your total score. If you pass one of them, you'll subtract 10 for the one that you don't complete, or 20 if you don't subtract 20 from your total score if you don't complete either of them. Promoting interoperability generally as usual, but with some minor differences. Simplify it, offer no bonus points, convert the 10 points, convert the entire score to a 10-point maximum, and invert the calculated score to subtract from the quality to cost score. So if you have a perfect promoting interoperability score, you don't remove anything from your total score for the program. If you do nothing in promoting interoperability or don't qualify for any score, you end up removing 10 points in total from your total score. They're proposing a complex patient scoring adjustment, similar to that how it works in general, based on HCC risk score and/or the proportion of dual eligible patients in the practice. It will compare these across the entire cohort of participating practices, and if you have at least one of those scores higher than the mean amongst your compared to your peers, then can adjust your score upward by somewhere between 0 and 10 points. Proposing a small practice scoring adjustment. Of course, participation is as an individual, but if that is an individual is in a small practice, more than one, and less than or equal to 15 clinicians, to get 10 points added to the score. You have to have some score in the program to qualify for the small practice adjustment, and also for the solo practice adjustment, which would be 15 points added to the score if it's a solo practitioner participate in the program. So the proposed scoring, again, is to take the quality score to account for half of the weighted score, the cost score to account for the other half of the weight, improvement activities, subtract 0, 10, or 20 from that total score, promoting interoperability, subtract 0 to 10 points from the score, complex patient adjustment to add 0 to 10 points to the score, small practice scoring adjustment, 10 for small practices, 15 added for solo practices, with the final score between 0 and 100, not to go below 0, not to go above 100 points. A unique approach to selecting, to randomizing the group in this program by community. Now, the Office of Management and Budget has a infrastructure in place that they're using for other things. Some of the names associated with this or concepts associated with this are the core-based statistical area, the metropolitan statistical area, metropolitan divisions, micropolitan statistical areas, generally dividing the nation and the territories into communities around some population center and common service and commuting activities. They're proposing to eliminate areas that are entirely within U.S. territories and eliminate areas that have no eligible clinicians with at least 20 eligible episodes in 2024, leaving them with 600 areas to randomize. They're proposing to stratify the communities by high and low cost, by high, low, and very high volume, including one stratum just for the largest metropolitan areas that are divided into 31 divisions, and to randomly select 40% of each stratum to be included in the study group, with the other 60% to be control groups for this trial program. And in the bottom of this slide, bottom right-hand corner, is got as a representation of how that will map out. Now, provider inclusion, that is any provider that is in those regions. And that'll be determined by the zip code of the practice where they provide the plurality of their care. It has to be a clinician who bills claims under the Medicare physician fee schedule, that is Medicare Part B, identified as a tax ID number, NPI, has a selected specialty type. For heart failure, just one specialty, that is cardiology. For low back pain, anesthesiology, pain management, neurosurgery, orthopedic surgery, physiatry, any of those specialties. As a TIN NPI, that is at that level, the practice through which you bill, you meet the relevant episode-based cost measure, 20 episode minimum volume. If you don't hit that 20 episode minimum volume, or not included in the cohort, they're proposing not to apply the low volume thresholds that have been common since the start of MIPS, but to substitute just this 20 episode minimum to establish that floor on the volume. They propose to identify participants on an annual basis using applicable data from 2 calendar years prior to each performance year. Now, I'm not sure how this is proposed to to work out. But in one sense, they're saying once you become a participant, you're a participant for the remainder of the model. But they're also proposing to measure eligibility every year. So I'm not sure how they're proposing to have that balance out. Certainly, you would not be facing scoring and adjustment if you're under the case minimum in any particular performance year. They're proposing to use 2024 data to create the preliminary list before the end of 2025, and then 2025, data to create a final list by August of 2026 for a January 1st, 2027 start date. I think it's an important program because there's some new wrinkles in this that are likely to inform future options and future directions of the program. I can see this becoming the foundation for the MIPS Value Pathways program. Certainly, the mandatory participation is an interesting element to say if you're eligible for a measure, you must participate. I think it's interesting that it's limited to individuals and not to groups. It opens up the possibility that we won't be looking at specialty. There's a couple times in this rule where the specter of specialty is raised, and some of the difficulties Medicare is facing to try to understand specialty for any particular provider. This might justify a future change to service line rather than specialty orientation. That is, if you generate the episodes, if you participate in the episodes that give you a 20 patient minimum in any of the episode cost measures, that might be the measure in the future of eligibility. I think that small mandatory measure set is an interesting pattern that we might see more of. We're seeing it now in the APP measure, that is the APM performance pathway measure set, that all ACOs are required to submit that same set of measures. This for these two measure sets is similar, and Medicare has been expressing some frustration that they don't have that direct comparison between practices when there's such a broad choice provided for measures. It is an interesting perspective on low volume. We've been experiencing the low volume threshold since the onset of MIPS in 2017. But substituting that for that 20 case minimum instead of the patient count or total billing that have been going into that traditional low volume threshold. Also, the higher adjustments since MIPS has reached its runtime maximum, although the Medicare has, in general, reserved the right to increase the total, the range of gain loss. This is the first we're likely to see something above a plus or minus 9% delivered. And it's also interesting we're going to face a problem with, or a phenomenon in this program that will have providers singled out to participate in this program who also are in practices that have to submit the APP for ACO participation, or where the whole group is in a group submitting situation for their usual MIPS analysis. So interesting to anticipate how we'll deal with that and where that goes in the future, whether that becomes a non-starter or becomes more of a theme as we go forward. So there it is. It's an important new program. I thought it was important to give you a little bit more focus on that. Don't forget to submit comments if you have them. They're due by September 12th. And the business day, I recommend that you enter them online at the Federal Register. Go to this link. Click on the green box to submit a public comment, and watch for the final rule to be released in the Federal Register on or about November 1st of this year. And don't hesitate to, I like looking at the Electronic Code of Federal Regulations when I need to refer to the rules between or outside of the rulemaking cycle and the publication of the proposed and final rules. So thanks for joining us today here at Ask Dr. Mingle. Use the links here on the right to submit additional questions, correct my answers, contribute your experience and comments. Remember, we are smarter together.